We welcome any comments or questions, and all materials are provided for your educational use. Now I'd like to introduce our speakers for the webinar. Molly Quisenberry and I are both patient safety advisors with the Patient Safety Authority. We both interact with patient safety officers and other various healthcare staff to identify hazards and reduce patient harm and risk. Molly covers facilities located in the north central region of the state, and I cover facilities in the northwest region of the state. Molly, now I'd like to turn the program over to you.
Thank you, Rick. Good afternoon, everyone, and welcome to the third webinar in the Keys to Investigation series, Everyday Investigations. The Investigation Keystone is an opportunity to meet with your patient safety advisor to self-assess your current investigation process. Your patient safety advisor may have already reviewed the investigation assessment with you. If not, he or she will be reaching out to you over the next several months to complete it. This Keystone project aims to provide the development for healthcare professionals to improve their knowledge and skills of the investigative process. There are a total of 8 webinars in this series, from reporting an event through the investigation to the implementation and evaluation of your action plan. Webinars are interrelated but stand alone. If you missed the first 2 webinars, they are or will be available to view on the Patient Safety Authority YouTube channel. In-person workshops will be offered in the spring of next year to apply the information learned from these webinars. The benefit of participating in the Keystone Project is not only to improve your knowledge and awareness of the resources used in the investigative process, but also to use the findings from your investigation to improve system design and ultimately patient safety. Shelley, if you could please post a link to the current Keys to the Investigation roadmap in the chat box, that would be appreciated. The roadmap includes registration links to the future webinars, as well as a link to the first webinar that is now available to view on the YouTube channel. I would also like to note that the resources Shelley will be posting in the chat throughout this presentation can also be found at the end of the packet of presentation materials that you've already received. Our objectives for the presentation today are to list daily sources of information that can be used to identify that an event occurred at your facility, learn methods to prioritize the investigation of events, and review the resources and documentation that can be used to finalize investigations. So you are the patient safety officer, the risk manager, or perhaps a member of the quality and safety team. You come in on a Monday morning after a refreshing weekend off, and where do you start? How do you learn about what type of events happened over the weekend or currently going on in your facility? Do you need to investigate every one? If so, which ones do you investigate first? And what type of investigation do you choose? If you attended our Outside the Box webinar series earlier this year, we talked a lot about all the other sources of information you can use to find out what is going on in your facility, in addition to your internal event reports, which is a requirement to have per Section 307 of MCARE. Shelley, if you could please put a link to the Outside the Box webinar series in the chat box, that would be great. In addition to your internal event reports, some other sources of information you can use to find out what happened in your facility might include, for example, if your facility participates in a daily safety huddle or safety rounds, you may learn about an event there. Perhaps you have a safety hotline that staff or patients can utilize to report a concern. There may be an event that is discovered by your medical records team through doing a concurrent or retrospective chart review. Depending on the size of your facility, or if you work in a surgery center, in addition to your responsibility as the patient safety officer, you may also function in a clinical role, and you could actually be involved in the event. Now that you're aware that an event occurred, what do you do next? You need to start to gather some preliminary data. You need to find out what happened. For example, if you learned about an event through an internal event report or one that was discussed at huddle, You might first begin by looking at the patient's electronic health record or chart, or calling or emailing the unit manager or staff involved where the event occurred to obtain some additional information. If it was an event that involved a fall, there may have been a post-fall huddle document completed that is available to review. You may have sufficient information from the event report, the phone call, or exchange to have done a quick analysis of the event, know the cause, and report it before completing a more thorough investigation if a more intensive one is necessary. Meaning, you may have enough information from that initial communication that the cause may be apparent. Other investigations may require a little bit of a deeper dive to find the underlying root cause or causes. The type and depth of your investigation may also depend on whether the patient was harmed or had the potential to be harmed. So what comes first? The investigation and then reporting, or the reporting and then the investigation? Well, it may depend on the type of event. Does it meet the definition of a reportable event per MCARE? If it does, you're probably going to prioritize and report those events that are time sensitive first: infrastructure failures and serious events. Sometimes you may need to report before you do a thorough investigation. Briefly, just to review, per MCARE, a healthcare worker is obligated to report serious events and incidents no later than 24 hours after the occurrence or discovery of a serious event or incident to their internal reporting system. This might be a paper event report or an electronic one that your facility has a contract with through a software vendor. A medical facility has an obligation to report serious events and infrastructures within 24 hours of the confirmation of the occurrence of the serious event and infrastructure failure to PA Pacers. A medical facility has 90 days to report an incident to Pacers. So let's talk about some types of events that may and can probably be reported before doing a deep dive. An infrastructure failure. So you arrive at work, and when pulling into the hospital parking lot, you notice the fire department is outside your facility and some staff have evacuated the building. When you ask what happened, you learn that there was not a fire, but that the smoke alarm was activated and the fire department showed up. During morning huddle, the director of facilities reported out that one of the nurses on the med-surg unit burnt his toast, which activated the alarm. There was no patient or staff harm. You probably have sufficient information to get this reported immediately, since this would be an infrastructure failure due to the activation of your fire response system. Let's talk about a serious event. You received a call from the director of surgical services that a wrong site surgery just occurred in the operating room. Since your facility practices candor, communication, and optimal resolution, you were asked to come to the OR to participate in the debriefing process with staff. You learn an elderly patient with dementia consented for a left knee arthroscopy in the surgeon's office. However, the OR schedule noted it was a right knee arthroscopy, and therefore the room was set up for a right knee. The patient was taken back to the OR prior to the surgeon arriving, as there were many cases that day and the surgeon was consistently late. The surgeon marked the right knee and the procedure was completed. The wrong side event was discovered in PACU by the patient's daughter when she noticed the dressing on the right knee. Since there was apparent patient harm and some system failures, you definitely will want to do a deeper dive into this event. However, you probably have enough information now to report this as a serious event. So you work at a surgery center as a pre-op nurse, but also function as the patient safety officer. You have a patient that is scheduled for cataract surgery. All cataract patients are instructed to have nothing to eat or drink after midnight. The morning of the procedure, the patient reports to the pre-op bay. When you ask when he last had something to eat or drink, he excitedly tells you that he just ate the best pancakes ever at a great diner down the road. I'm sure this sounds familiar to some of you out there. When you tell the patient that his procedure is canceled because he ate, he admits now that he does remember being told this when he received his pre-op instruction call a few days ago, but he has since forgot. Again, you have enough information to report this as an incident. Although this type of event does not need to be reported within 24 hours to Pacers, you should try to report it as timely as you can. This might be an event that you track and trend to identify a common cause for the cancellation, for example, not adhering to NPO instructions. In case you may not be familiar with it, we do have an ASF cancellation and transfer tracking tool available on the Patient Safety Authority website. This tool provides surgery centers the ability to track and collect cancellation and transfer event information and rates in order to identify trends and evaluate the costs of these event types. Shelley, if you could please post the link for the tool in the chat box, that would be appreciated. Thank you. So it's time for our first polling question. As a patient safety officer, do you need to investigate every event? We'll just give you a few minutes to, or I should say a few seconds to answer that question, not a few minutes. I see some answers coming into the chat box as well. Okay, it looks like we're slowing down. So Shelley, if you could please close the poll. So it looks like a majority of the responses are yes. And I see something in the chat box that says you or delegate. So we're gonna talk about the answer to this and over the next few slides. So regardless of the type of investigation that you do, per section 309 of MCARE, if you are the patient safety officer, you are required to ensure the investigation of all reports of serious events and incidents. So yes, you do need to make sure that they are completed, but you don't have to do it by yourself. You are probably already doing this on a daily basis and may not realize it. Like when you review the patient's chart or electronic health record and call the unit manager to find out what happened, you're essentially starting that investigation. You are also required per MCARE to take such action as immediately necessary to ensure patient safety as a result of any investigation. In the example with the wrong site surgery, if you learn that there was a violation in policy regarding the consent process, the site marking, or timeout that could impact other patients having surgery that day or in the near future, you would definitely want to need to take immediate action. You are also required to report to the Patient Safety Committee regarding any action taken to promote patient safety as a result of investigations commenced pursuant to this section. So keep your Patient Safety Committee in the loop as to what types of events are going on in your facility and what you and your team are trying to do to prevent future occurrences. And per section 310, among other things, your Patient Safety Committee is required to evaluate the actions and investigations of the patient safety officer. Hopefully your Patient Safety Committee includes engaged members that are offering input and feedback on your patient safety efforts. In case you're not familiar with it, we do have some resources available for Patient Safety Committee agenda ideas and community members on our website. Thank you, Shelley, for posting this in the chat. If after your initial investigation, you uncover additional details about the event, you will want to not only update your Patient Safety Committee on this, but also you'll need to update your internal patient safety report and the PACERS report. You have up to 90 days to amend a report in PACERS if necessary. We greatly appreciate and rely on this information, so please try to remember to do this as well. So back to our polling question. So if you are the patient safety officer, Does this mean that you need to do this all by yourself, investigate the reports? For MCARE, the obligations of the patient safety officer include to ensure the investigation of all reports. This does not imply that the PSO needs to take this on by him or herself. If you have the resources available, collaborate with those also involved in the event. For example, work with facilities management if it is an event involving anything to do with the infrastructure of your facility. Make sure there is a process in place for the facilities management team to notify you or another designated individual if there is an event that occurs while you may not be there, like a power outage. Some infrastructure events may also trigger your infection preventionist to be notified as well, such as an issue with temperature and humidity in the ORs or a water leak. Work with your preventionists in the investigation of healthcare-acquired infections. Utilize hospital or unit-based teams for falls, or PT or OT if the event occurred while the patient was there. Many facilities use a post-fall huddle to document the investigation. Consult with your wound care nurse or skin team if the event involves a hospital-acquired pressure injury. Work with your unit directors or department managers of the location where the event occurred. If you work in a small facility or a surgery center, you may not have as many resources available, so leverage what you do have. For example, many patient safety officers will often share the patient safety responsibilities with the director of nursing or administrator. Don't forget to include the pre-op, peri-op, PACU staff, as well as central sterile processing and surgical techs for their expertise, depending on the type of event. In the event that we talked about involving the surgery cancellation, wrap in your pre-op nurses. Are your pre-op instructions clear or health literate regarding NPO instructions, or do they need to be updated? Some internal reporting software has the capability to send an alert or email, not just to the primary location where the event occurred, but also to a secondary location. For instance, if a med area occurred on med surge, the primary area might be med surge, but you could also send the alert to pharmacy to review as a secondary location. Since we have been discussing the types of events that are reportable per MCARE, I briefly want to mention a few other event types that you may be familiar with. A sentinel event, a serious reportable event, or a serious safety event, and a candor event. Just to clarify, these event types are not the same as a serious event. While there may be some overlap in their meanings, they each have differences. These event types are more prescriptive than serious events as they involve a list of specific events versus a definition. How you respond to and investigate those types of events will depend on regulatory and accreditation requirements as well as facility policy. For example, if you're a Joint Commission accredited facility, you may not be required to report a sentinel event, but are required to complete a root cause analysis. If your facility practices candor, you probably have a facility-specific criteria that meet the definition of a candor event and a response team that is responsible for conducting a preliminary review within hours of the event, if not sooner. This review is not meant to take the place of an in-depth review. It is an opportunity to respond to the immediate needs of those involved, gather time-sensitive materials, and begin building a trusting relationship required to move effectively through the event review. It also establishes the core team responsible for conducting a more in-depth analysis. If you're interested in learning more about candor, we do have resources available on our patient safety YouTube channel. So Shelley, if you could also post that in the chat, that would be great. So we've talked a lot about some events that may not require an in-depth investigation, or at least an in-depth one before it needs to be reported. So why do we even need to do an investigation? The sole objective of the event investigation and analysis is the prevention of future adverse events. An investigation should not be used to assign blame or liability. As you can see from this slide, the more questions you ask and the more details you get about an event, the more valuable the information becomes. You always want to start your investigation with asking broad, open-ended questions like, tell me about what happened, followed by, what normally happens? Was there any deviation? This is important to get a global perspective of what is going on. This can also help to identify any workarounds that have been established, which is a sign a process may need to be improved. Then you need to find out what is supposed to happen. Many organizations will begin their investigation with what does the procedure required, and this can put employees on the defensive. We want to create an environment that is not threatening so we can learn what happened and what normally happens. It's not until you investigate that you might find an opportunity to prevent future occurrences. Next, find out why did it happen. This is the analysis phase of the investigation. The purpose of this phase is to discover reasons that explain why an event occurred. We're going to talk about some types of analysis in just a bit that can be helpful in determining that. Finally, the management phase of the investigation, meaning when an adverse event occurs, does your facility look beyond human errors to the systems and behavioral choices within those systems? Does your facility hold those that caused the event appropriately accountable but make fixes to prevent future occurrences? These are elements of a just culture, which is beyond the scope of today's presentation. Every day, as a patient safety professional, you are doing investigations to determine ultimately why an error occurred to prevent it from happening again. The premise of a systems approach to event investigation and analysis is that while adjusting individual performance may appear to resolve the case, it does not ensure the event won't happen again. Human errors are abundant and inevitably repeated. Error is human, right? This, however, does not eliminate the need for highly trained individuals with competency standards, thus the need for physician and nursing peer review. It is worth noting, however, if an event does go to peer review, although it may be peer protected, there may be a system issue that is identified in the review that needs to be channeled back to the patient safety event investigation team. If the focus of the investigation is on the process and the system factors that facilitated the error, the process can be adjusted to minimize human error, resulting in fewer opportunities to err again. So let's briefly review the relationship between human errors and system factors and adverse events by talking about my favorite kind of cheese. Yep, you guessed it, Swiss. Unless you're new to patient safety, I'm sure most of you have heard of the James Reason's Swiss cheese model. How patient harm happens is based on a systems approach. The stack of cheese represents your organization's safety system. Errors are prevented by defenses, barriers, and safeguards as represented by each slice of cheese. The defenses, barriers, and safeguards are things such as technology, processes, people, and culture. Ideally, each slice of cheese should remain intact. The slices of cheese are designed to stop active failures, which are caused by individuals. This would be things like human error, a slip, a lapse, a mistake, or a violation. Holes in the cheese are caused by both active failures and latent conditions, which are weaknesses in the system. Latent conditions can cause opening and closes in the holes in the defenses. When the holes line up, it brings hazards to the patient. So in the wrong site surgery event we discussed earlier, the staff and the provider were more than likely violated a rule in bringing the patient back to the operating room before the site marking, which could be the active failure. Active failures should be addressed at the individual level. However, it sounds like this surgeon was consistently late, so perhaps his lateness and thus marking the site in the OR became an accepted practice or workaround, which very well could have been a culture issue or a latent condition. When the holes lined up on this particular day for this particular patient, a wrong site surgery occurred. When doing an investigation, you'll want to look at your facility's slices of cheese, your defenses, barriers, and safeguards to identify the latent conditions in your system or the contributing factors. Identifying these weaknesses will help you target or zone in your areas for improvement. For example, in the wrong site event, there may have been an opportunity for improved communication between the surgeon's office and the OR scheduler as the incorrect information about the site was placed on the OR schedule. Or maybe there was a locum or new OR staff that day that was not aware of the site marking policy. While learning from one high severity event is necessary and often uncovers process gaps, there are usually multiple acts that lead to harm and multiple system causes leading to those acts. Determining where to focus limited resources becomes a challenge. At times, it is necessary to prioritize the approach to the vulnerabilities in our system. I would now like to turn the presentation over to Rick, who will discuss how to identify these vulnerabilities and find the why in the analysis phase of an investigation.
Thanks, Molly. As Molly mentioned on one of her previous slides, investigations are done to determine ultimately why an error occurred to prevent it from happening again. One investigation technique you can use is the 5 whys. The 5 whys is an interactive interrogative technique used to explore the cause and effect relationships underlying a problem. The goal is to determine the root cause of the problem by repeating the question why. Each answer forms the basis for the next question. And I'd like to just briefly go over a real life situation that some of us may have encountered in our life. So you go out to your vehicle in the morning and you go to start it and the car won't start. So that's a problem. Well, why won't the battery or why won't the car start? The battery is dead. And then in my case, I would end up calling AAA and having them show up and assess the situation. But it's determined that, the battery is dead because the alternator isn't working. Then the next question would be, the alternator, why isn't the alternator working? Well, the alternator belt is broken. And logically, the next question would be, well, how did that happen? Well, the alternator belt was well beyond its useful life and was never replaced. So the notice to actually have that replaced was ignored. And so then you get to the 5th why, which is the root cause. Why was it never replaced? Well, the car was not maintained according to the recommended service schedule. So we want to determine why an event occurs, but the depth of your investigation depends on the type of analysis you are doing. What I have up on the screen right now is a chart that may look familiar to those of you who attended the how to determine a type of investigation webinar last week. This chart is done in the same format, but the criteria is different. Last week, the presenters discussed and actually compared and contrasted the 3 different types of analyses that we'll be discussing and have discussed. The criteria discussed last week, for example, focused on event type. A single event or a single or similar few related cases for the apparent and root cause analysis, where there are many cases involved in identifying trends over time for the common cause analysis. The degrees of harm were one of the criteria discussed at the last webinar. No harm, limited harm, near miss versus high harm for root cause analysis. The target of the analysis, an obvious mistake or failure versus underlying cause or commonality for multiple events. And then goals for each of them, where you're talking about the apparent cause analysis, you want to learn and understand the event versus identifying and eliminating system level root causes for the root cause analysis. And then for the common cause analysis, you're focusing in on identifying common etiologies or causes of the event over time. So let's talk about each of those reporting analyses or investigation analyses in a little bit more detail. So with the apparent cause analysis, it's a limited investigation of an event used to investigate the cause or causes of a medium or low risk safety event or no harm events, such as near misses that occur in a discrete work setting which do not cross departmental lines. So going to Molly's previous discussion about the reporting of an infrastructure failure involving the activation of a fire alarm, you want to look at this and take a look at exactly what the problem was. Well, the problem was that the fire alarm was activated. And well, why? Well, a toaster on one of the units started smoking. Well, you ask again, well, why? Well, the setting was too high. And then the employee didn't check the setting to ensure that it was at a safe level. And in terms of a corrective action plan, you might do something like do a sticker system where to remind the employee to check the setting before they start to heat their toast. Or maybe a more high leverage intervention would be just not permitting to have toasters on the units for this reason, because they potentially can activate the fire alarm system, or more severely actually cause a fire. When Molly was discussing the events in terms of the MCARE requirements, and that an investigation needs to be done on all events, in terms of the apparent cause analysis issue, you have the opportunity to have in place information from unit managers or from the fall team or post-fall huddles that would provide you the information you need to complete that investigation. So and one of the things that I wanted to go back with was I'm not sure if I covered the actual aspects of the criteria for what we were going to discuss today. With regard to the apparent cause analysis, they probably occur most frequently. As Molly mentioned, they're probably occurring without your sometimes knowing that you're doing apparent cause analysis. And to a lesser degree, but does occur somewhat frequently, or root cause analyses compared to common cause analyses, which are less frequent. You have the resources when you're talking about the apparent cause analysis that are less and limited in terms of the number of individuals involved in the apparent cause analysis versus the resource intense root cause analysis, where it's a multidisciplinary team that's part of the investigative process. And then to a lesser degree, there is less resources involved in common cause analysis, but it may involve other disciplines. So when you're talking about the process, you're talking about what's involved with the apparent cause analysis is an obvious failure or mistake, compared to the what's involved with the root cause analysis, where you're defining the problem and brainstorming the potential causes, understanding the causes and effects, and designing one or more solutions to remove variability. Now, with regard to the common cause analysis, you're synthesizing learning from safety events, apparent cause analyses and root cause analyses, identifying common etiologies, and facilitating broad, far-reaching improvements. And as far as the examples go, what you focus on is the what and how for the apparent cause analysis. With the root cause analysis, you're focusing in on the how and the what, how, and why, and systems that are involved in the event, versus the common cause analysis, which has a broader, far-reaching scope in terms of its improvement recommendations, and it would involve things like people, leadership, environment of care, or communication. So I just wanted to reiterate that. So with regard to the apparent cause analysis and the activation of the fire alarm system, it's an apparent cause is pretty easy to actually ascertain. And as Molly mentioned, you could report this, with just a brief investigation. And then, as I mentioned, with the falls, you're talking about taking advantages of other resources available to you in your facility. When you are talking about root cause analysis, the root cause analysis focuses on significant events, involves several departments and a number of different individuals. Typically, a root cause analysis is performed in response to a single patient safety event. Um, and the Patient Safety Authority does have resources on its site to actually assist in the completion of a root cause analysis. I know, don't know, Shelley, if I guess you've already posted it in your in the chat box, but these resources run the gamut in terms of assistance in completing the root cause analysis, starting with the root cause analysis investigation form and guidance document for the root cause analysis investigation, as well as an event analysis timeline and cause and effect diagram. One of the things that I find most helpful as part of that process is the action agenda, because it's helpful in being able to track your improvement strategies in terms of making sure that there's a targeted date for completion and identified responsible parties for completing the action plan. So going back to our wrong site surgery case, if you recall, this was an elderly patient who consented to left knee arthroscopy, but the OR schedule indicated that the right knee was to be done. The room was set up for the right knee, and the right knee was marked, and a wrong site surgery occurred. So taking a look at those, the 5 whys, the problem is that there was a wrong site surgery occurred. And then why? Well, the incorrect leg was marked. The incorrect leg was marked because the room was set up for the opposite leg, and the schedule stated the opposite leg. And then, well, why? Well, the source documents probably weren't checked to verify that it was the left knee. The consent wasn't checked to make sure that the left knee was the one that was actually to be done. And again, too, we do have in the chat box already posted is the tools that we have available on our website for wrong site surgery resources. You just have to go to the topics, and this link will get you right to it. But if you're in on our website, you just go to the topics in the upper left-hand corner and go to wrong site surgery, and all the tools will be listed there for you. The same thing applies in terms of wrong site surgery for healthcare acquired pressure injuries. We have a situation here based on the picture that I'll just sort of run through a quick scenario. An 86-year-old female was admitted from home. Skin assessment did not identify any present on admission skin issues, but the skin assessment was not completed each shift, and the patient developed a pressure injury on her heel. And so you go through the process of what you need to do in terms of the root cause analysis. You may include nursing, the PCTs on the unit, the providers involved, physical therapy, dietary, and skin team. In this particular case, the staff did not have time to complete the assessment on a per shift basis. And what happened was the electronic medical record for the facility allowed the skin assessment from the previous shift to be carried over to the current shift with the idea that the staff would be making changes to that, but the staff never got around to it. So it appeared that, the heel of the patient and everything else in terms of the patient's skin integrity was intact for the staff. So there is a final guidance on the PACER's website for the pressure injury assessment and decision tree for making a determination for pressure injuries. And then last but not least, where root cause analysis is typically used for a single event. Common cause analysis aggregates causes from multiple events to identify the common causes of those events. While it is beneficial to identify root causes for process gaps and single events, using common cause analysis to examine multiple events allows organizations to identify the depth and breadth of the system vulnerabilities. Aggregating all of the root causes and the analyses from an institution or system is one way that to use common cause analysis. And when you really think about it, this is essentially what the Patient Safety Authority does. Aggregate analysis provides an opportunity to identify broad trends unapparent on an individual scale. A single facility may only experience a small number of events each year, but by analyzing trends in reports from across Pennsylvania, the Patient Safety Authority analysts can detect patterns that are not noticeable to a single facility. For example, the Patient Safety Authority analysts have identified manufacturing defects in new products that were initially considered user errors. And remember, the more detailed reports the Patient Safety Authority receives, the better it can help you help your patients. So the discussion of the surgery cancellations, again, would be something all ambulatory surgery facilities, for example, in the state are required to report their cancellations. So this would be something that is probably identified as one of the more frequently reported events by ambulatory surgery centers. So doing a common cause analysis would be helpful to see, what the common elements are for facilities to focus on. You can also, in terms of preventing those events from occurring. And it's also used for medication error review. Medications, for example, in a facility, you might be able to identify a trend with missed doses. In a review of reports, the common thread that most missed meds in a particular facility were at, for example, 2 p.m. And the nurses involved in these events were all agency staff and not used to the facility having a 2 p.m. medication administration time. So that was flagged, and you could address that through the common cause analysis process. So what I want to do is go over I actually want to just test your knowledge with a sample event. It's rather long. It covers 2 slides. So what I'd like to do is just go ahead and read through it and have you do some voting on the actual questions that are the polling questions that we've listed. A nurse from the behavioral health department was pulled to ambulatory surgery for the day to assist with pre-surgery phone call assessments. The computers were down, so she used the paper preoperative screening assessment and the surgery checklist provided. She called the patient, who was an add-on case for the following day. The patient was a college student who was home on break and needed his wisdom teeth removed. She went through the series of questions on the checklist with the patient, including asking the patient if he had a history of malignant hypothermia. The patient wasn't too sure what The nurse wasn't too sure what malignant hypothermia was, but the patient promptly answered no, and there was no other staff readily available to ask what this meant. The patient reported to the ambulatory surgery the following day with his mother, who was his designated driver postoperatively. There were still some glitches with the computer, so the decision was made to continue with paper charting. The CRNA evaluated the patient in the pre-op and reviewed her usual series of questions with the patient, including whether the patient had a personal history or if there was a family history of malignant hypothermia. The patient's mother reported that there was a family history of malignant hypothermia on the patient's father's side, but they are now divorced, so she wasn't sure which blood relative it was. Since this was new information, and general anesthetics had been in use all day in the ORs, the patient's procedure was canceled and rescheduled. So just real quickly, as part of the polling questions, would you report this particular event? So responses would be yes or no. Okay, let's see about closing that and what the responses are. Well, great. I like when that happens. So 100% of you that responded would report it. Next polling question, would you do an investigation? Okay, let's close that particular polling question. Again, 100%. And then the last polling question, what type of analysis would you choose? Parent cause analysis, root cause analysis, common cause analysis, none of the above. Let's close that particular polling question. Now we have a little bit of variation there, but almost 2/3 of you are saying apparent cause analysis. Only 27% are saying root cause analysis. So, just real quickly, we have a risk matrix here that uh, is used to actually determine based on severity and frequency, whether there needs to be a root cause analysis done. This was actually a form that was developed by the VA, National Center for Patient Safety. And you'll see that the information provided uh, uh, goes from a score of 1 to 3, with 3 being the highest score. And one of the important things about the VA's policy is, or their risk matrix, is that there is a root cause analysis that's performed for events with safety assessment codes scoring at 3. And for near misses, even if the event is a close call, as in this case, which we just went over, you assign a severity based on the reasonable worst case, which for this would be the potential was there for it to be a catastrophic event. And as such, even though the information in terms of how frequently this occurs would indicate that it's somewhat remote, the score would come out as a 3. And actually, you would do a root cause analysis on that particular event, because based on the risk matrix, it scores at that higher level. This slide was put in to actually talk about the specific event that we just went over. The problem was that the surgery was canceled. Was what was the that's the problem. What was the reason? Well, it was that there was a family history of that was unknown regarding malignant hypothermia. Why? Well, it was not asked by the nurse that did the pre-surgery assessment. And then why? Well, it wasn't on the paper copy of the assessment that was in use at the time that the nurse did the assessment. And then, well, why? Well, the paper assessment form had not been updated to coincide with the electronic form that was usually the one that was in use at the facility. So even in the case of an event where there is no harm, when you take a look at it from the perspective of severity, you'd probably benefit from doing a root cause analysis. Uh, so with regard to investigation tips, you want to find the type of investigation, fit the type of investigation to the event. You do a deeper dive for those events that cause harm or you have potential to cause catastrophic injury or death. Sequentially, you ask why until you reach an actionable response, and then make sure that you are investigating what you're trying to prevent. In terms of documenting um, your investigations, it's an important element of the investigation process. Uh, oops. Uh, so you have your internal event report, and the more detailed you are, the better it helps you. But in regard to your submission of a PACERS report, the more detailed reports that the Patient Safety Authority receives, the better the Patient Safety Authority can help you help your patients. And you saw the number of tools that we have available um, on the Patient Safety Authority website to assist facilities with different types of events and investigations. As Molly mentioned, you have 90 days to amend the reports, and then we want you to emphasize questions 12 through 20, which would be the questions that actually deal with recommended best practices, lessons learned, what corrective action was taken. That's helpful to the staff and the analysts at the Patient Safety Authority to identify best practices and ways of preventing harm to patients going forward. You have your investigation forms. You have mini root cause analysis form that a lot of people refer to as part of an apparent cause analysis. Other information would include post-fall huddle, post-fall healthcare acquired pressure injury huddle or debrief. And then, as stated before, the Patient Safety Authority does have its own a root cause analysis educational site, and we do have our own form for completing a root cause analysis that we provide to facilities. IHI also has a lot of information regarding root cause analysis, and they have their own form as part of their RCA squared program, as does the Joint Commission. And then you could also have your own facility specific root cause analysis form. The other types of investigation forms, like the Excel spreadsheet, where you're taking a look at, for example, infections and what's actually occurring in your facility, if it's a surgical site infection, where if there was a specific OR involved or staff involved with the cases that have surgical site infections post-discharge. What you want to do, though, is you make sure that you close the loop because actually there was a webinar that we did towards the end of last year entitled Using the Feedback to Break the Black Hole of Event Reporting. And it emphasized how important it is to provide feedback to staff regarding events that are being reported. So many times we would hear that staff are discouraged because they're completing event reports, but they don't really hear anything more about them once they submit them for review. So this helps motivate staff to report and also improves the reporting submission process for staff, especially when they know that something actionable is actually taking place with regard to the events that they're submitting. And then takeaways for today. Good reporting benefits all involved in the investigation process. Investigate as needed and as required. Investigate events that caused harm or could cause harm to patients, visitors, or staff first. Delegate in investigations when you can. Use a risk prioritization matrix to assist in determining what type of events require a more in-depth analysis. You want to track and trend to identify common threads that cause an error. Use debriefs, post-fall huddles to determine apparent cause of an event. Keep scheduled root cause analysis meetings on the calendar if possible. I know that a lot of facilities have problems with pulling together staff to do root cause analyses, especially the appropriate staff, and probably having a time set aside to do this. If you don't have an event that needs to have a root cause analysis, then you can just cancel the meeting. But having that organized time does expedite that whole review process. Discuss results of investigations at the patient safety committee and solicit feedback on your efforts, and update PACER's reports with additional details and recommendations. And then a good investigations focus on what happened and led to system improvements. And so I know we're running out of time. Well, Molly, one of the things maybe that you can discuss is I know that we've had questions in the past about ways to keep your investigations on track. And I know that you've had some discussions with facilities in terms of what they've actually done.
Yep. Well, one of the things that, we talked about in the webinar today is, of course, delegate when you can. Utilize your facilities management, your infection preventionists, your unit directors to help with the investigation. Some facilities will do a daily safety huddle, and that way they can, the patient safety officer that attends the huddle, as well as the department managers, the patient safety officer is able to get real-time feedback on events that maybe, he or she has reviewed in the morning before going to huddle. So that's a great way, real time to be able to get some information back, and then use that huddle the following day to follow up on those events as well. Another suggestion that I had from the facility, and this was really great, is that they are able to, before they have a daily huddle also, and before that huddle, they send all the department managers all the outstanding event reports, and they color code it green if the report does not need a further follow-up, that the investigation is complete, red if they need a follow-up investigation from the managers within 1 to 3 days, and then yellow if they need a follow-up in 5 to 7 days. And that's just a way of keeping everybody on track. So I appreciated that suggestion as well.
Yeah.
Do you have anything to add?
I don't, let's see. Oh, we might have time for one quick question. When reviewing internal event reports, how can you prioritize events that need to be addressed first? So, Molly, I think also you had received feedback about this. I know that there's software that's available that can filter out specific taxonomy categories and all, but I wonder if you could just elaborate a little bit more on this particular question.
Sure. There's certain software, if you have like an electronic reporting system that can filter out maybe events that you track and trend that are commonly like incidents, like those surgery cancellations or a lot of lab events where the quantity might be insufficient. That usually there's not patient harm, but they can event types when they have a chance, or they could filter out by your harm score as well. So if you have anything with a harm score of E or higher, that you can look at those events first. If you don't have that capability, for an electronic system with that internal software, then that would just be a manual process, but you could do, basically the same thing. I want to thank everyone for joining us today. If you experienced any issues accessing the evaluation and/or certificate of continuing education, please feel free to direct any inquiries to Shelley Meixel at shmeixel@pa.gov. This concludes our webinar.